Hello, my name is Eric Tan. I'm assistant professor at the University of Southern California. Today I'm going to present a case series of patients using the Orthopedics DynaNite Nitinol staples for traumatic nonunions. So first we have to figure out, one, what are nonunions and why do they occur? A nonunion is where a bone doesn't heal. So in a situation where you have a fracture or in a situation where you've done surgery and you've cut the bone, when these bones don't heal, usually in a time frame of 3 to 6 months, we call that a nonunion. And we have to understand, how do these occur? Well, fracture healing depends on a complex interplay of two factors. One is mechanical stability, and two is biological potential. So when you have an issue with one or both of these factors, this is what leads to non-healing or non-uniting of the fracture. And this subsequently causes pain and dysfunction to patients. In this case, we're going to present the use of the Orthopedics DynaNite Nitinol staples. There are certain factors and properties of these staples that make them unique and helpful for this complex situation. One, they have continuous compression. So in this situation where you want increased stability, the continuous compression of the staple provides that. In addition, it has a low profile. So if you want to supplement this with an additional plate, additional screws, you have more real estate to do so. In addition, there's also multiple sizes. So these range from small sizes such as 9 by 7 millimeters all the way to 25 by 25 or 25 by 20 millimeters. Finally, they're easy to apply, they're easy to deploy, and also if you need to take them out or revise them, you can reload them and reuse them. And all of these are very helpful in these situations where you may have limited real estate in order to create this healing potential. So this is a case of a metatarsal nonunion. She had a metal pipe that fell onto her left foot. Initial images were negative. She had continued pain though. So 6 months later, she saw her primary care provider. They ordered an MRI and it demonstrated a left second metatarsal base fracture. She was subsequently treated with cam boot immobilization as well as a bone stimulator. So these radiographs here are radiographs from 6 months after her injury. We can see a fracture line still visualized at the base of the second metatarsal, resulting in her continued pain and dysfunction. She wished to continue with non-operative treatment, and 12 months later, she was just unable to get fully out of the boot and return to her activities. So we can see there's again the visualization of the fracture at the base of the second metatarsal, as well as sclerotic changes of the bone consistent with a non-union of the bone. We therefore discussed with her surgical intervention to correct the situation. So here's an MRI. We can go through the MRI here. We'll see edema in the second metatarsal, as well as the fracture line in the second metatarsal base as well. So for surgery, first we identified and localized the non-union site. We went ahead and debrided that site. We removed any fibrous tissue, any of the sclerotic bone. We prepared the bony surfaces using K-wires and osteotomes to provide a fresh bed of healing. And then essentially we addressed the two major issues. For mechanical stability, we took advantage of compression across the fracture manually with a clamp, and then we supplemented this with a Orthopedics Nitinol staple. And we see in this area where there's small real estate, we're able to apply the staple and provide compression across that fracture site. And then we elected to supplement fixation with a dorsal metatarsal plate across the tarsal metatarsal joint for increased stability. From a biological perspective, we added concentrated iliac crest bone marrow aspirate. This would be to provide additional factors to promote healing as well. These are immediate post-operative radiographs. We can see good alignment and placement of the hardware. And then at 3 months post-operatively, so she was kept non-weight bearing for 2 months. We advanced her in a boot after the 2 months, and then by 3 months she was back into shoes and she was walking. She wasn't having any pain dorsally over the foot. We can see through the x-rays there are no new sclerotic changes or new fracture lines identified. So in conclusion, non-union surgery requires addressing both of the major factors, mechanical stability as well as biological potential. We need both of these in order to have a successful result and a successful fusion. In addition, in this presentation, we're demonstrating the use of the DynaNite Nitinol staples, which provide a low profile, continuous compression, which are ideal for situations like these with potentially limited bone and healing. Thank you.